vibrate over.
900. You got some maybe close to 1,000 if it's good hay.
My grandson had done. My wife was not happy.
But, you know, I'm sorry to involve you. When
No,
I
it's fine.
But yeah, but I'm not kidding. I told Terry, I said,
Yeah, yeah.
Scaled down for
Well, then this one friend of mine, I sold some to him, good hay. Second or third year seeding corn grass, and I says, well, for you, $50. I said, something.
What is that?
A friend of mine liked to buy 2 3 bales. I said, well, $60. We took 3 bales, but I haven't seen the money yet, so I'm hoping he comes around with that.
Just a quick announcement before we begin. If you'd like to speak to the county board during the public comment time, you must fill out a registration slip and turn it into the county board chair prior to the start of the meeting. Registration slips are located at the front of the room on this table over here. Please keep in mind that the county board will not be able to respond to your comments or ask you any questions. Your comments are informational only. If further action is required, your comments or concerns will be directed to the appropriate department or committee. Thank you.
Are you, Bob?
Better.
Oh, that's right. You doing better now?
Oh, yeah, I was sick of the dog.
Yeah, if you like the job. Then
Yeah.
From your foot?
she's the only person.
Couple of things, yeah. I had a foot infection. I had a vertigo attack. A vertigo attack. I felt like I was drunk without the fun. I've fallen off of walls, and
Thanks, Ruthie.
So you just have to live through it.
I did what I did best. I laid in bed.
I was in the hospital for 8 days.
How you feeling now?
Better.
Good. Yeah. Smoking dope helps.
Could you speak more into the mic, please?
No, I don't mind. I'm in favor of legalizing the herb.
Digging himself a deep hole, sounds like to me.
Tell us what you really think. That's hysterical.
Well, they wanted me to agitate, so I'm just filling the role.
There you go. You're doing it, huh?
That just had
Who, you?
Yeah, I got a kidney stone about the size. This is about the size. Yes, Thursday night I went into Wild Rose. And they did all the X-rays and that. And better by Monday. You better go see a urologist. I know I drink more water than you would believe. It's different things. Obesity, they say. Too much salt in your diet. Well, I can't put the salt shaker down, so that's. So he said he give me some dope. And
Okay,
some
it's 7
dope
o'clock.
acid,
I think we'll call the meeting to
surgical
order.
removal, and that don't sound like fun.
Mel,
So I'm hoping.
we'll do roll call.
Mrs. Krentz.
Here.
Mr. Jones.
Here.
Mr. Tim.
Here.
Mr. Piaski.
Here.
Mr. Eckstein.
Here.
Mr. Weddy.
Here.
Mrs. Plata. Here. Mr. King.
Here.
Mr. Wadle.
Here.
Mr. Crawford.
Here.
Mark Kirschner.
Here.
Okay, we'll have silent prayer and pledge of allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. We now have public comments, and I don't see any sheets on my desk here, so we will move right on to the approval of the agenda.
Madam Chairman, I move to approve the agenda as presented.
Motion by Weddy, second by Crawford. Any questions or comments? All in favor?
Aye.
Opposed, same sign. And now we need an approval of the minutes of the June 18th, 2013 monthly meeting, and there is one change on page 2. Under dining meeting room donation, in the second paragraph, Department of Aging currently contributes $150 per month instead of $250. So that has been changed to $150 a month.
And also to the senior center, not the, or for using the facility too. Not to the city.
Okay, yep. I've got that there. Okay, yes, she does have this, that correction made. Thank you.
I'd move to approve the corrections.
Motion by Weddy, second by Waito. Any questions, comments? Hearing none, all in favor?
Aye.
Opposed, same sign. All right, we are gonna move down to old business, and there is none. And under new business, our first order of business will be a report, and that is the EMS assessment results. Thomas Little from Fitch and Associates LLC will give us our report.
Thank you. My name is Tom Little. I'm a paramedic. I work for Fitch and Associates as a senior associate. I've been with the firm for about 10 years and had the pleasure of coming out here a few months ago and looking over the EMS system. I met with Brian, the EMS director, and tried to talk to as many of the employees as I could get scheduled in during that time, as well as other stakeholders in the community regarding ambulance. So the way I like to try and do these reports is I'll tell you a little bit about how we did the report and what the goal was. And I'm not going to go through the report pretty much as you see it, because you can read that. I think it's fairly self-explanatory. There were several sections in there, and I've kind of developed a grade card. And I'll show you the grade card here in a second. But for each section, I've scored the categories in that section as a red, which means it needs improvement, a yellow, which means it is in progress or you're working on it, or a green means that it's working rather well. And I'll try and move through this fairly rapidly. I've got about 37 slides to go through, and they've told me I got about 30 minutes, and I'll entertain some questions afterwards. Basically, the consultants is Fitch & Associates. We've been in a consulting business since 1997, and the founder of the firm, Dr. Jay Fitch, is a former EMS director from the city of St. Louis and Kansas City, Missouri, and broke off into the consulting business because we found there was a lot of ambulance services, both government and private and hospital-based, that needed help. They just needed advice on how to do various different things and to stay out of trouble and do things more efficiently. And out of his firm, there's two other partners who are also in the EMS business. We only do ambulance. We don't do anything else. We do air ambulance, we do ground ambulance, but we don't venture off into anything else other than just ambulance. The project scope, see if I can go the right way here. The scope of the services requested, basically we were to do a fiscal review of the EMS operations, looking at the current and previous audits and any special audits, as well as our independent work. We did a review of the EMS operations. We looked at the organizational structure, how the organization was put together with the leadership. We looked at clinical care. We talked to the medical director and the medics about the care that's being offered. And overall, the whole EMS system. And when I say system consists of starting with 911, starting with people in the community that may be able to render some care, that know CPR or could use an AED, the medics themselves, the fire guys, the medical first responders, the hospitals we transport to. All of this is part of a system. So we tried to look at the whole system overall, not just the ambulance itself. And then we offered up some recommendations on sustainability, on areas that needed improvement or could improve in efficiency. Now you may ask, what right do I have to come in here and look at this and analyze your EMS system, because I'm not from here. I've been a paramedic for 37 years. I'm still licensed in the state of Kansas as a paramedic. My last operation with the Fitch & Associates organization was to manage an EMS system for a hospital-based service for 5 years up in northwest Missouri. So out of that, I've been actively involved in the leadership of ambulance operations, and I'm still a licensed medic. So I stay up on the clinical side of what's going on with things, and I really believe in looking at a lot of different systems. I have some pretty good ideas on how we can make things work a little bit better. So I'm not just somebody that doesn't know what's going on. I've been involved in EMS for 37 years. When we look at the methodology of what we tried to do in this site visit, We had materials and data that we collected. We did on-site interviews, and we made direct observations on how EMS is operated. We compiled the data. We brought in the input of the stakeholders that we met with, the fire chiefs, the ambulance personnel, hospital people that receive the patients, and even fleet people who take care of the vehicles and things like that. We then applied benchmarks to the key standards. We looked at how this is done in other communities of the same size and locale so that we could see how are you doing it here in Waushara versus how are they doing it in other communities the same way. And we developed benchmarks, and I'll explain some of the benchmarks as we get into them. We looked at future states. What will EMS look like in the future? And things are changing with healthcare reform. And ambulance has a fairly significant role to play in the future of healthcare. And then we created a report. I gave a draft copy of the report to the leadership to look at to make sure that the technicalities were correct and accurate. And then we issued a final version, which I think you all have had for about a week to look at and develop some questions if you have some. In summary, it's a county department. You provide advanced life support, emergency responses, and you're in a very highly rural area of Wisconsin. WCEMS, which is Waushara County Emergency Medical Services, has posted significant financial losses and is looking for ways to remain sustainable. The county's committed to providing an emergency paramedic service, as well as enhancing the EMS system and doing a more efficient or better job. I came up with 65 recommendations for changes. Some of these recommendations are basically continue to do what you're doing in some of these areas. Some of them are totally new and do things differently than what you're doing. Those recommendations are all summarized at the back of the report, and they're also contained throughout the report as you read it. The 8 essential elements for evaluating an EMS system is how this whole report is put together. We look at communications, we look at medical first response, the medical transportation, which is really a big piece of this, the customer community accountability, how do we affect the community and how accountable are we to the community, ensuring an optimal system value. You want to make sure that as we look at the finances, that we're charging the right, we're spending the right amount of money, that our finances are right. Then we look at prevention and community education. One of the benchmarks for ambulance services throughout the country is how they help the community do a better job of healthy living and provide education. And then, of course, the organizational structure and the leadership of the department. So anyway, this is how the scorecard looks, and this is our communication section. I've taken the 8 categories. Communications was the first one. In the report, you'll see in a little box contained in there these specific benchmarks. And these are things that we looked at very specifically to see whether or not Waushara County EMS was performing these or not. So the first one is public access to an E911. I graded that a green because you do have that. It's working very well. That's something that you all have achieved. Single PSAP exists. The PSAP is the Public Safety Answering Point. It's at the Sheriff's Office. You have one of them. It exists, and it works quite well. There's minimal PSAP handoffs. You'd be surprised how many communities I go into, and there's multiple destinations where 911 calls go into, and then you have to hand that call off to the ambulance service in a whole variety of different ways, and sometimes it just doesn't work well. In this area, that works well. The next one is certified personnel. Are the dispatchers, EMD, or emergency medical dispatch certified, and do they offer pre-arrivals, and is that portion of it medically supervised? No, it's not. One of the things you have is you have the software to be able to do EMD. You have the ability to train and certify the dispatchers in emergency medical dispatch, but that has not been done. Plus, the medical director is not involved in looking at the protocols for dispatch to make sure that they're medically appropriate and they follow the medical plan. Data collection supports analysis. When I was here, Brian did not have access to the sheriff's CAD in order to be able to produce reports and look at data and collect that. I understand that has changed. Brian and some of his staff have limited access to the EMS data specifically only, so that he can start running some of his own reports and be able to categorize things that are going on. Technology supports interface. You know, I graded that a yellow because the interface is available for the technology, but it's not, the bridge has not been completed. And what I mean by that is there are several pieces of technology. There's the CAD in the sheriff's office. There's the mobile data terminal in the ambulance. There's the laptop computer that the medics do their patient care report on. And then there's the billing system that sends out the bill. None of these things are connected with each other. What should happen is when a call comes into the CAD, that data should be able to be transmitted seamlessly to the mobile data terminal, which works sometimes, but there's some technology issues with that mobile data terminal and the locating devices in them. It does not connect to the patient care tablet or laptop. The crews have to get a fax from the sheriff's office with their times on it and information, and then the medic's got to enter that in by hand. That should be an automated process. The bridge should be available, but it just hasn't been interfaced. And then, of course, the tablets should interface with the billing system, so all that data just flows from the CAD through the mobile data terminal, through the laptop computer, into the billing system, and it's all seamless. Those interfaces don't exist, but they're available. AVL, GPS, you all know that AVL is automatic vehicle locating. It tracks for dispatch to assign the closest ambulance. It doesn't work well. It's there, but because of geography and radio systems and the ambulance parking in garages and areas where it loses its connectivity, when you lose connectivity with this AVL system, it shuts off. And then when you pull out of the garage or you need to reconnect, sometimes it can take up to 10 minutes for the satellites to find the AVL and the ambulance and connect again. And by then you're already underway. Sometimes you're at the scene, and it's just not working as well as it should. So we think there needs to be some improvement in the with some of the IT people maybe in making the AVL work better for the ambulances for the sheriff's dispatch. And then, of course, the adequacy of radio communications. Yes, there's dead spots. There's dead spots in every community. But for the most part, you have some pretty good coverage of radio communications in the area. Plus, the ambulance has a cell phone. It has a two-way radio. I mean, it's got more than just one means of communications. So this is kind of how the scorecard looks. And this is how I will rate the different 8 categories that we'll talk about. Some of the recommendations that came out of the report is we really recommend the sheriff should get and implement EMD immediately. And we do this because people expect it, especially in a rural environment like you have where ambulances take a while to get there and it takes a while to get the volunteers out and get to the scene. A whole lot of care can be issued to a calling party prior to the arrival of anybody. And in most communities, this is up and running. People see it on TV. They expect it to occur. And it just makes sense. I mean, there's been countless lives saved with a dispatcher telling a calling party to clear an obstructed airway, take care of a shock victim, start CPR. A lot of that just takes place prior to the arrival of anybody. The best responder in an emergency are people out in the community that are trained and can get some help in order to start providing care. The medical director must be engaged in the medical oversight of the communication function, because if you are giving pre-arrival instructions or you are determining whether this is an emergency call or a non-emergency call, you really need to have the medical director involved in this, because we all operate under our medical director's license. As paramedics, we don't go out and just practice medicine. We have a physician that oversees all the protocols and everything we do. And that physician needs to be engaged in the system that I talked about earlier in all aspects of it. And right now, he's not engaged in the communications piece of it. Allow the EMS system to have selected reporting rights. Just talking to Brian, that's pretty well been done and set up. He and his staff are learning how that works, and so I think they've implemented that one already. Medical first response. There was 2 recommendations in that category. First of all, medically supervised first responders and a single system medical director. We have that. The medical director for the ambulance service is also the medical director for all of the medical first responders, and that's good. Response time standards for first responders. You know, when I spoke with the fire chiefs and said, how fast can you get to the scenes? They said, well, generally we get there in around 5 minutes. Okay. Well, generally and around aren't specific time standards. And NFPA, the National Fire Protection Association, has specific guidelines for rural fire departments on how fast they should respond to medical alarms. And all it takes is just running the reports, because the Sheriff's CAD has that data as they dispatch the fire departments to scenes, and the trucks go en route and they go on the scene. I mean, all that data is available, but nobody's accumulating it and putting it into a report. So, you know, we think the fire guys do a good job responding, but we can't prove it. And part of the work that I do is I work with a lot of data to prove the effectiveness of how things work. So, you know, I gave that a red mark because nobody really knows how good the fire medical responders respond. And we need to get a better handle on that. Fire response agencies report fractile response times. Okay, you may hear a lot of guys say, well, on the average, we get there in about 5 minutes. Well, you know, an average is 50% of the time. That's half. We work on the 90th percentile fractile method, and what that means is 90% of the time we're getting there within a particular time standard. Not 50, 90%. We know we can't serve everybody all the time within the standard. There's always going to be a few outliers, but that should only be 10%. So as we look at looking at response times, we really want to measure that based on a 90% fractile time rather than just an average. And most fire departments are still stuck back in the average categories. AEDs, automated external defibrillators on all first-line apparatus, yes. You know, in fact, I'm very impressed with the number of AEDs that are out in this county. The EMS system and the county itself, because I think you guys fund a bunch of them, there are AEDs in a lot of places, and that's really good. In fact, I'm staying at a campground out of town about 10 miles, and they've got an AED on the campgrounds, and I think that's pretty cool. Smooth transition of care. How well do the medical first responders hand off the patient to the ambulance crew when they get there? And I understand it works well. The medics report it works well. The fire guys report it works well. So I gave that a green. That's a passing score. There's a good, smooth transition of care. When somebody is hurt or injured, it starts with the fire guys getting there and follows through with the ambulance, and the patients just know they got good care. So in our recommendations in that area, we really want the medical first responders to increase their interaction time with the medical director. I don't think they're really using the medical director as well as they could to make sure that their protocols, which are the same ones as the ambulance service, their protocols are up to where they need to be and their people are trained and properly certified. First responder time should be reported from the time that the call is received by the fire department until that vehicle stops at the scene, and that should be reported according to NFPA standards at the 90% mark within a certain time standard. And that should be handed off to the ambulance service so Brian can report how well the system works. And the system includes the fire guys. Medical transportation. I got several categories under medical transportation. This is ambulance and operations. We want to make sure that there's defined response time standards, and you don't have any. You go and you get there, and it is what it is. We've not measured response times in the past. We haven't set a standard for that, so I'm recommending that that takes place. Again, the agency reports it as a fractile, a 90 percentile, not just an average. We want to make sure the units meet staffing and equipment requirements, and they do. Every ambulance has a paramedic and an EMT on board. The equipment, the ambulances are well equipped. They have good equipment on board and are fully equipped to handle any emergency that comes along. So they got a green score. Resources are efficiently and effectively deployed. You know, I gave that a yellow because we have ambulances throughout the county, over in Poisippi and up in Plainfield and Coloma and Watoma. We kind of move that one on the west side back and forth every 30 days, which I don't think is very efficient. The Poisippi unit, it's there. It just doesn't respond to a lot of calls because there's just not a lot of calls in that area, so I'm not sure how efficient that is. So I think that's something that needs to be worked on. Smooth integration of care between the medical first responders, EMS, and the care facilities got a green because that works well. And there's no bigger fan of the EMS system than Wild Rose Medical Center is up there. The ambulance service and Wild Rose works very, very well together. I interviewed people down in Berlin at the Berlin Hospital. They had nothing but great praise to say about the medics and their interactions they have with that. So this is all very good. The medical staff of the ambulance service interface very well with the other caregivers that they interact with. And, of course, maintain and develop a coordinated disaster plan. Brian has worked very closely with the emergency manager at the sheriff's office. The crews seem to be properly trained in National Incident Command classes. There are disaster drills that gets practice, and I think you guys are prepared. So some of the recommendations under this category is that key staff members should be assigned to the quality management function and trained in quality improvement and statistical process control. I like data. Data proves what it is that we do and that we don't do well. And I think more employees should be involved in that. There should be a scorecard developed that's used on a monthly basis or at least quarterly so data can be easily utilized to improve patient outcomes because we do everything we do for the patient. And if you don't look at the data and know how well you do, you may think you're doing okay, but you ought to be able to prove you're doing okay and then share it with the community. Effectiveness of a quality improvement program is required to maintain modern practice standards. We just don't have a good quality improvement program with EMS. That is changing. Brian's already started making some changes in that, but we just haven't done that in the recent past. So, medical accountability. This hovers more around the medical director. The benchmark is a single physician medical direction for the system, and you have that. You have one doctor that is responsible for the ambulance service, the medical first responders. He works at Wild Rose, so he's involved in the medical care facility there. We need to get him involved in the communications center. He's willing to do that. We just need to bring that together to fruition and make that happen. The doctor should have a written agreement with roles and responsibilities and goals that he's supposed to be performing. Right now he's doing stuff, but there's no agreement to just enforce that. A lot of communities have medical directors by signature only, and we want to make sure yours is not like that. We want your medical director to be engaged into the EMS system, understand it, and actually participating in it. There is no written agreement, and I've given Brian, some templates to be able to work on a scorecard and get an agreement in place. There needs to be specialized training and certification. The medical director has that. He is an emergency physician. He's involved in the military reserves, and he keeps up on those things that he needs to have in order to be a good quality emergency physician. So you have that. And the physician reflects national trends. He's up on things that are going on. He's a smart guy. He's a good choice for the EMS system. Proactive, interactive, retroactive medical direction is facilitated by the medical director? No. He's doing some stuff, but we haven't defined what he needs to do. So we need to make what he does more interactive with the organization, define it, and measure it. So there needs to be the job description of the director or the deputy director should be modified to make sure that quality management duties are included in that. We need to regularly measure both clinical and operational skills and use appropriate remediation processes to ensure that the staff maintains required competencies. When I talk about competencies, we need to make sure that they've kept their NIMS training up, kept their BLS certification up, their ACLS up, any of the pediatric certifications that are required to have to make sure that they can intubate, they can start IVs, they can recognize people in shock, and they can apply the proper protocol for that patient once they've identified it. There needs to be an audit, 100% audit, of patient refusals to make sure that the crew properly assessed the patient and it was the right thing to do to not transport the patient to the hospital. And in any system, you'll have a couple of medics that are burned out, or they don't want to work that hard that day, and they'll talk patients out of going to the hospital. And if you have a good audit of patient refusals and somebody's looking at those, then you'll just know that that's not occurring here. Your non-transport rate was 18.6%. The national benchmark for no load or no transport validation is between 17 and 20%. So you meet the benchmark. It doesn't appear that there's any abuse, but it's just always a good thing to audit those anyway, because those are the ones that will come back and get you sued or have a lot of liability for. Fleet and logistics. There needs to be a good capital fleet replacement plan in place, and you have that. Every year or as needed, the county funds the purchase of new vehicles. Your fleet's not that old. It doesn't have that high mileage on it. It's well maintained. I just took delivery of a new ambulance not too long ago. So that is in place. You'd be surprised how many communities don't have that. Critical failures and accidents are tracked per driven mile. No. You guys don't have a clue how many accidents you've had compared to the number of miles that you travel. And that's an important number, because we can't go wrecking ambulances. An accident will occur once in a while, but it's my opinion, after being in the ambulance business for 37 years, that if that vehicle is in motion and it gets hit, the driver has some degree of preventability of that accident. Now, of course, if you're stopped and it gets rear-ended, can't do much about that. But we train our drivers under the EVOC program, which is Emergency Vehicle Operations course, to watch out there and expect everybody to be wanting to hit you. And if you've got that mindset, then you're going to be able to avoid accidents, and you shouldn't have very many accidents. When you have an accident with an ambulance, it takes that ambulance out of service for months. And you just can't go down the street to Enterprise or Avis and rent an ambulance and use when your ambulance has been damaged. So we need to track those. We don't know how many times the ambulances broke down on a call. And you never want to have an ambulance break down on a call. But we don't track that. So we've talked to Brian and the county fleet guy about tracking some of these things, and that's going to happen. Driver training, EMS safety, EVOC courses are frequently taught. Your drivers are certified for 3 years when they take an EVOC class. In my eyes, that's not enough. Emergency ambulance drivers should go through an emergency vehicle operations course every year. Even though that certification is good for 3 years, you need to keep that safety out in front of them. And one of the things, and I teach EMS safety because we want to make sure the medics can go home in the shift, that they don't get injured by some means or killed. And if you watch the EMS clipping services, ambulances are involved in accidents every day. And frequently, EMS people are being killed throughout the country because they don't wear their seat belts, they drive too fast, they're fatigued. There's a number of things that happen, but we need to make sure our people go home in the shift. So driver training is paramount. Quality, control driver technology on board each unit. You guys have some drive cams on the ambulances, and what a drive cam is a camera focusing in front of the vehicle as well as in the crew cab, and it's recording constantly. But if there's an incident and something happens, it captures about 45 seconds before the incident and 45 seconds after the incident, so you can actually see what took place. And when there's an accident, you can actually see by that drive cam who ran the red light. You can actually see by that drive cam what the crews were doing in the front cab of that ambulance when an incident occurred, whether it was a curb strike or a sudden evasive procedure or an accident. And the crews know when they have these things on, they're driving just a little bit better. You have these cams in most of the vehicles. There's some issues with the technology or the interface or the software that needs to be upgraded. Brian and I were speaking about that this afternoon. That needs to be fixed. There's also some, we call them black boxes, that can be put in vehicles that measure centrifugal forces and abusive driving and wear and tear on these things, abnormal excessive speeds, rapid decelerations, sharp cornering. All these things are tough on ambulances. It measures that. Kind of pricey, but it certainly will make the ambulance last longer and decrease your fleet costs. So, one of my recommendations, and this is one of them, maintain a capital fleet replacement program. You have one, don't get away from it. This is important. Black box technology will benefit the fleet. Anytime we install these black boxes or the drive cams in an ambulance, the people drive them better, and it helps make sure you don't get involved in an accident, and it reduces your maintenance costs on these vehicles. Review driving policies to bring in line EMS safety. Use a spotter when a vehicle is in reverse, and have a no tolerance policy on safety infractions. You never, these aren't cars. You can't see around them. If you have a driver backing up without a spotter, you can hit something. And you can tell that when you look at the rear bumpers of ambulances, whether or not a spotter has been engaged. And all it takes is to run over a curb, hit somebody that's sitting on a sidewalk because you just can't see them. Medics hate to get out and back people up, but that's the only way you know you're not going to hit something when that vehicle is in reverse. Make sure your fleet maintenance processes are continuous. Your fleet program, I think, is working well. I spoke with the guy in charge of fleet over at the county shop, which does the maintenance. He's got a good handle on how often he ought to be doing oils and filters and tires and brakes and things. And your cost per mile is the best way to track sustainability. Cost per mile is fuel, labor, and parts divided by miles. Do that every month. That way, when an ambulance starts getting expensive, you can start looking at it, catch it before it becomes a big expense item, and take care of it before you have problems. So your cost per mile is the best way to track your fleet. Your units appear to be adequately staffed, adequately equipped, and the guys, for the most part, are pretty well following policies and things like that, and I think they seem to be in pretty good shape. Medical transportation, your preparedness. You got all green marks on this. Brian's done a great job, and so has Jeremy, in working with the emergency manager in the county to make sure that staff is trained to the National Incident Management System specifications, has all the training to make sure that the system has an all-hazards preparedness approach, which means you've gone through some risk processes. You understand what the risks in the community are and how we impact EMS. And there's been examples of interagency disaster training take place. Sometimes ambulance is left out of disaster training, and so when a real disaster happens, our guys don't work real well with the fire and the sheriff's people because we weren't included. But in this case, in your county, they are included, and disaster drills are held, and that's worked out real well. So you got all green marks in that category. So why did I have recommendations? You know, you probably need to expand the hazmat education. We know that when we come across a hazmat incident, the further away we are, the better it is. But sometimes in this rural environment, that's not necessarily something that's going to happen. So if the guys are properly trained to protect themselves when they show up on a hazmat scene, that education is important. Evaluate the EMS role associated with risk evaluation and mitigation planning for a large healthcare system. You know, all it takes is a 747 flying over your county to come down in one of the cornfields, and you've got a major event. And just to plan for these things is good to make sure that you know what's going to happen at the hospitals, and who you're going to call for help, and how you're going to handle this stuff. And then practice. Practice. The hospitals need practice disaster drills for their accreditations. They need the ambulance to help them with that, so it's a good partnership to do disaster drills. Crew configuration and technology. Staffing pattern follows the best staffing model. You know, I gave this a yellow because I'm not exactly sure without the data to show that we've placed our ambulances in the right spot. Right now, we're alternating on the west end between Plainville and Coloma. You know, it really probably ought to just set that thing down in Hancock and leave it there. Get a station there so you're just keeping that ambulance in one spot on the west end. I think you'll find your coverage will be much better, and it helps everybody know where the ambulance is and can count on that. The Poisippi unit, you know, I hesitate to say take anything out of there because there's not a lot of volume, but when a call does occur there, it takes a long time to get someplace. And if that ambulance isn't there, then that's really a long response time. So I'm not exactly what the best idea for that staffing model in the east end of the county is, and I really don't like 2 ambulances running out of the same station. It just does not make any sense to me. And in Wautoma, we have 2 ambulances running out of the same station. If we can separate those things out a little bit, it improves our coverage, maybe move one up towards Wild Rose. Your Red Granite area has a lot of calls. And it's tough to get over to Red Granite from either Poisippi or Wautoma in a timely fashion. So maybe we need to look at that. And this is stuff that Brian can all work out by looking at data and figuring that out. You know, another benchmark is adequate part-time staff to minimize overtime costs. You're doing that. An interactive electronic patient care report with the CAD, with the billing interface, which provides a single consolidated information resource you don't have. That's what we talked about earlier. We don't have those interfaces in place, making the data flow seamlessly from one program into another and making it all one database. We don't have that. Quality CAD with wireless technology and current mapping and AVL interfaces in place. You know, it's in place, but it doesn't work well. We lose connectivity a lot with the mobile data terminals and the AVLs, and it takes a long time for it to come back online for the dispatch to see it. It's just not working well, and I think there can be some IT improvements on the wireless technology to make that flow better. So what are the issues? We need to prioritize the technical issues with Sheriff's Dispatch to have access to reporting specific data to EMS, and I think that's underway. The CAD to improve wireless coverage, that's an IT function we need to work on to improve wireless, either it's in the stations or however the towers are set up for wireless communications. We need to work on that because, you know, the dispatcher needs to know where that ambulance is. That's just important. We really need to consolidate the stations in Coloma and Plainfield into that single station at Hancock. I know you guys have looked at that. You've thought of it. It makes the most sense, and you ought to do that. The Poisippi station, wow. You know, I know you guys need to be out there, but that is configured in such a way that the crew quarters is literally 100 yards away from the ambulance. And at 2 o'clock in the morning in February, when it's 10 below and it's snowing, and that crew has to trek 100 yards from the crew quarters to the station, is not reasonable. And it's adding easily 4 minutes to your response time. So instead of responding to somebody that needs help and getting there as quickly as we can, we're spending easily 4 minutes trying to get from the crew quarters to where the ambulance is garaged. So we need to work on that one. After tracking 911 data and the transfer data, you know, we may find, especially since we've lost some work in Mountain View, that reducing the number of hours that second unit is in Wautoma down to a 12-hour car or something. But that will all be data-driven, and Brian's working on the data now, so we'll see what that means. But, yeah, it might be a way to save some hours if we're just not running the volume of calls, especially since those 2 ambulances are garaged in the same building. Interfacing the CAD, the patient care report, and the billing data components is really essential for the best use of technology. Response utilization demand. Boy, this one doesn't look good. Response coverage matches demand by geographical areas. Well, we never measured that. In your report, you have a map. And in the map, we plotted every call in 2012 and where it was on the map so we could figure out where the calls are occurring. If you don't know where the calls are occurring and can prove it, then you don't know where to place your ambulances. Defined response time targets exist. No, we don't. We're working on that. You guys kind of measure response times, but you don't have a target to shoot for. Individual response components are measured to the 90th percentile metrics. No, we still look at averages, and we need to move that to the 90th percentile. System monitors safety and response time issues. No, we don't monitor safety. We don't know if the crews are using backers. We don't know how fast the ambulances are driving. We don't know if they're stopping for red lights and stop signs. We don't know really what's going on. So no, we're not monitoring the safety, and we're not monitoring response time issues because we're not measuring response times. In a system that you're measuring that, every time you have an ambulance show up late, there should be a report issued. And the report may be nothing more than it was just a long ways to get there. But you should look at that and measure that and monitor that. Here's the map. We basically took all the calls in 2012. We plotted them out in the community. We identified where your stations were. And the light yellow represents a response time factor of 19 minutes and 59 seconds, or basically 20 minutes, to get anywhere from the station. The little darker yellow areas are cover over. It's where multiple stations can respond to that call within that 20-minute period. I chose the 20-minute period because right now, and we were not able to differentiate 911 calls and transfer calls, so the times were a little skewed. But right now, your 90 percentile is about 25 minutes. But that includes all the transfers. And once Brian can break out the transfers and just look at 911s, I think that's going to come down better. But NFPA, Medicare, everybody recognizes this is a rural community, and the response time standard should really be about 20 minutes. So you've got a lot of overlap. You've got some areas that, I mean, I think you're hitting just about all of the calls within the 20-minute factor. So as we look at different stations, and in the back of your report are actual maps of each station, of that station alone, how far that footprint goes out around that station within the 20-minute factor, and gives you an idea what that station can respond to. It's pretty interesting data. We also measure ambulance calls by day of week and hour of day. This chart didn't work for me as well as I wanted it to because, frankly, you don't have enough calls to really come up with a good analysis of this. But what this does tell you, you can look at it and get a feel for how the calls flux throughout the day, when you're busy and when you're not. You can easily see that on a Monday, the night's pretty quiet. It's a Sunday night going into a Monday morning. There's not a lot of activity. But about 8 o'clock in the morning, things pick up. About 10 o'clock, you're as busy as you're going to be for the day. It slows down a little bit for the lunch period. And it might be transfers. At 1 o'clock, we pick it up again. And we stay kind of busy up until about 8 or 9 o'clock at night. Okay, go over and look at Tuesday. Tuesday's your slowest day of the week. And you can see that, again, about 7 or 8 o'clock in the morning, we see a little spike. 10 o'clock is about your busiest time. It ebbs a little bit during the lunch hour. 1 o'clock, it picks back up. And it's just, you can plot your calls. And this is how you do your staffing schedules. If this was a larger system with 10 or more, 15 ambulances on duty, serving 10,000 to 15,000 responses a year, I would be looking at short cars, shorter shifts, and taking hours off the system on weekends and cutting them back after about 10 o'clock at night and putting them back on about 7 in the morning. But you only got 4 ambulances, and you're spread out over a huge geographical area. And I can't in good consciousness recommend that you cut any unit hours at this point. If you can, it might be that second car at Watoma, and it might be during the night hours, but Brian's going to have to look at the data. But this is the stuff we can look at and make some educated decisions on what we want to do with staffing and locations. So anyway, Friday's your busiest day of the week. Tuesday's the slowest. June's the busiest month, while March was the least. There was no seasonal flux in your call volume for emergency medical services. I was told that the county's about 25,000 people and fluxes to 80,000 during the summertime. EMS told me that. County leadership told me that. The sheriff told me that. The fire people told me that. But when you look at ambulance calls, I'm not seeing a seasonal flux. So maybe these are healthier people, but I was concerned maybe you needed to add hours during the summer, but that's not the case. There's no statistical flux in the seasonal demand. That was interesting. We need to differentiate between transfer and 911 calls for the purpose of data monitoring, and Brian's working on that. We need to establish a response time standard of 19 minutes and 59 seconds measured at the 90th percentile for emergency 911 calls. Set that as a target, measure from that, and let's see how we do. We need to stop responding to all 911 calls, red light, and siren. It makes no sense at all. It's dangerous. Somebody's going to get hurt. Those calls need to be prioritized by dispatch. They talk to the caller. They have the information. They know the urgency. They need to dispatch these calls, emergency or non-emergency, based on the caller information. These calls need to be prioritized. System financing and funding, billing and reimbursement. Actually, I only had about 3 recommendations in this area. Patient accounts are billed timely and accurately. Yes, they are. Deduction for contractual allowances and bad debt relate to the payer mix. Yes, it does. The AR, which is account receivable, days and accounts, are within 50 to 70 days. I gave that a green mark even though it's 87 days. It's a little beyond that, but you guys have a great AR balance. So there's really no issues with that. Need to work a little bit on some of the third-party reimbursement. And we have some issues with Safe Harbor and HIPAA compliance. Safe Harbor means that you're following the laws that Medicare has laid out and that you're treating everybody the same. One of the things you guys are doing here is you're giving a resident a $175 discount. Well, according to Medicare, if you give anybody a discount, which is less money than you charge them, you have to give them the same discount. So you need to give, the government is supposed to get the best possible rate charged that's available. And if you're discounting residents by $175, Medicare could come back in and say, you need to give all of our people that discount too, because that's the lowest possible charge that you've accepted. So that's a problem. HIPAA compliance, you know, when a person walks in the front office to talk about a patient account, there's not a good place that they can sit down with a patient or a family member and talk confidentially about their care and their report and their particular stuff. You know, it's kind of out in front of everybody that may wander in or other crew members. And so HIPAA needs to be followed a little bit better in regards to that. So anyway, what's working here is your days in AR is 87 days, which is okay, just a little higher than it should be, but it's okay. You need to discontinue that resident discount of $175. If you got a person that's going to write a check out of their pocket because they don't have coverage, they haven't met their deductible, or they have a hardship, you know, there's hardship policies to work on. Grant them some type of a discount based on a one-on-one interaction based on their particular need, and you can do that. You just can't have a blanket discount for everybody, or you got to offer that to every Medicare patient, every Medicaid patient also. You'd benefit from raising your rates. Your base rate and your mileage charge could be higher in order to maximize third-party reimbursement money. You're leaving some money on the table with commercial insurance companies by not charging as much as you are for your base rate and your mileage charges. I'd recommend raising your base rate by at least $100 and your mileage charge by several dollars per mile. You'll not see any bad side effects from the community on that. If somebody's having a financial problem, you can work with them one-on-one on that, but you can bring third-party money back into the community that's not here. So that's something that would be worth thinking about. Compliance, documentation is a must. Just about every employee at EMS has their hands in the billing process to some degree. And that's a problem because they're really, if they have a question, there's sticky notes, there's tab documents, there's memos over here. There's no compliance manual in place that says how you're supposed to deal with an issue that comes along. And I think there's too many hands in the pie. I think with an EMS specialist on board, Heather, who understands patient billing, it's only 2,000 accounts a year. It's not a lot of business. We need to reduce some of the hands that are dabbling from the workforce into the patient billing process. And, you know, some of these guys do a good job, and they probably understand that piece that they're doing very well. It's just from a compliance aspect, it's too many people dabbling in it. So we need to realign the billing and collection activities under the control of the EMS specialist. Under your system costs, direct costs and revenues differentiated by operating unit. You know, typically that means if you have multiple cities and stuff in a bigger department, you know, can we tell which community is losing money and which one's not? You know, if we could do that by which station, by looking at the unit responding and look at the direct costs and revenues generated would be a good thing. Unit hour utilization by operating unit represents good value. No way. Your all's unit hour utilization is a 0.07. A good benchmark for that is a 0.35. And that's typically in a larger system that's more busier, but you guys just aren't busy. So I'm not saying that's a bad value, but in a benchmark, it just doesn't benchmarks with other services. And we'll get back and talk about that a little bit more in a minute. Your cost per call representing good value? No. Your cost per call is over $1,000 a call. And in a system this size, it's much less than that. Key performance indicators are monitored and acted on. You're not measuring anything. I'll give Brian some charts for key performance monitoring that he can look at. And then you'll know, because you'll benchmark this stuff, what your unit hour utilization should be, what your cost per call should be, and you can then decide, based in this community, whether or not it represents good value or not. But when we compare it to other communities, right now it's not. Regular investments of capital are budgeted and strategically planned. Yes, thank you. That is important, and you guys are doing that. Keep that up. Growth opportunities are evaluated as an individual unit with overhead considerations. You know, I think when we go into another community and they want us to provide ambulance services, we're looking at the per capita. I don't necessarily like that. I like to look at how many calls are they generating and how much is it costing us to provide services for that community, and then decide what's left, because we know what our costs are, but we don't know what our costs are. So Brian needs to get that under control, which he's working on, and then we'll be able to, I think, plan better when a community says, we want you to provide 911 services over the county line. You'll know what you want to charge them for that. And subsidies are evaluated annually and based on individual operating units' performance. You know, I'm not sure we really know what it costs to provide services down in some of the other counties that we're operating in. So monitor key performance indicators to facilitate cost-effective operations and sustainability. Your cost per call is $1,075. In other communities about this size, it's more around the $500 range. Unit hour utilization is 0.07. As I said a moment ago, a typical unit hour utilization is more around 0.3, even 0.25 for smaller community service. But 0.07 says that your units just aren't busy. What they're doing is they're providing coverage, which is important, but they're not busy producing revenue. And revenue pays the salaries, fuel, and overhead. So anyway, continue infrastructure investment and programs to improve the system's ability to measure results of the fleet and deployment of the units. Key performance indicators and tracking call demand is essential in making sure you're efficient. Community and customer accountability. System personnel provide good role models. Yes, they do. You know, these guys look good. Your ambulances look good. They're out in the community. They show up at special events. They're out there representing the county, and they're prepared. One of the things we know is anytime you have a gathering of people, the odds of a medical emergency occurring with a larger group of people multiplies, because you got more people there than not. So if you have an EMS unit close by, the chances of when that occurs, that they're close, they're going to render good aid. So it's a good thing. However, with moderation, you know, if you're having a fair, you know, one unit there is okay. You don't want them all there. But if you can have one there and they can rotate through, they're visible, they're providing protection, and it's a good thing. Programs are targeted to at-risk populations. You guys have an interesting program here where you can provide a GPS device to people with Alzheimer's and dementia and things like that. And if somebody walks away, they're easily found. And that's identifying an at-risk population and doing something about it. AEDs in the community. It's identifying an at-risk population and being prepared and doing something about it. So I gave you a green mark on that. That's good. Formal and effective programs with defined goals exist. No, there's no goals. We got the programs in place. We have no goals. We don't know if they're working. I asked, well, how many times has there been an AED activation? I don't know. Do we download the AED data? No. Okay, well, you got these programs. Let's define some goals and let's measure them. And that's the next one. Those targeted objectives are measured. So we want to make sure when we do something, let's set a goal for what it is we're going to accomplish, and then let's measure it and see whether this was worth anything or not. So we should publish some monthly reports of your statistics. The community, as well as yourselves, I'm sure would find it most fascinating how many calls you respond to, how many auto accidents, how many heart attacks, how many IVs do you start, how many whatever. I mean, measure this stuff and share it with the community and publish this stuff. Benchmark your internal issues. Continue internal staff committees for the betterment of the organization. There's nobody knows what's going on out there any better than the people with their boots on the ground. And if you ask them what works well, what doesn't work well, what tools or equipment do you need, they will tell you that stuff because they know it. So keep your staff involved in the committees because they know what it takes to do things better. Expand the quality improvement by setting goals and including staff. You guys don't have a quality improvement program. You guys need to get that underway. Your deputy director needs to lead that, along with the medical director, along with the crews and the staff, to make sure that you're following protocols, you're going to identify protocols, and that the care that you're rendering is quality. It looks like it is. It probably is. Everybody thinks it is, but we're not measuring it, so we don't know that. We cannot prove that. And I'll guarantee you, in the future of health care, Medicare and government programs will pay more money for programs that can prove that they have good outcomes. And implement a customer satisfaction survey. You ought to know what the community thinks about you. I think the community likes your EMS system, but there's no survey to measure that with. So a simple customer satisfaction survey would give you a lot of information on how well you're doing. Prevention and community education. I just did that one. Did I go the wrong way? Hello. Okay. Governance, growth, organizational structure, and leadership. Clinical outcomes enhanced. You guys don't measure that, so you don't know whether your clinical outcomes are effective. We don't know whether we're saving lives out there or not because we don't measure the outcomes. We don't track the cardiac arrests that we converted, that we took to the hospital, and they're breathing and beating when we took them there. We don't do the follow-up. We don't know how many of those there are. We don't know whether AEDs have actually contributed to converting somebody because we don't measure it. Unit hour utilization is measured, deployed, and efficiently and effectively measured. We don't do that, so we need to start. Cost per unit hour, cost per transport, document good value. You guys are expensive. It may be you're expensive because you just have a lot of dirt to cover and you don't have a lot of calls. You're providing availability. So we need to be able to track that and develop your own benchmarks for whether or not you have good value or not. Financial systems are accurately reflect system revenues, both direct and indirect costs, yes. Financially, you guys are tracking things with the budget and expenses, good. Revenues are collected professionally and in compliance with federal regulations. Other than a couple of things, yes, you guys are doing a good job with that. You're doing it locally. The people you have involved in it know what's going on, and that's working well for you. Local tax subsidies are minimized. I don't know that. You guys are collecting quite a bit of tax dollars, but until we can measure the other things we talked about, we don't know that we've minimized the subsidies. And it should always be a goal to minimize the tax subsidies as much as possible by bringing in more third-party money from the insurance carriers and those organizations. So the director and deputy director should pursue higher levels of education. I believe both of them are working on that. We should implement a staff rounding process to gain a better understanding of the workforce, and that rounding were things I said earlier. Ask the staff what works well. Ask the staff who they should recognize for doing a good job. Ask the staff what doesn't work well. Ask the staff what tools or equipment do you need to do your job better. And then catalog that and then give it back to the staff so that they know that you've listened to them and you're working on the issues that are important. Measuring costs, clinical outcomes, minimizing the reliance on tax subsidies are a priority, and it's all done through data. And then develop a clear action plan to address these recommendations. You know, additional considerations, there's a lot of talk these days about community paramedicine, where these paramedics go back to school, they get a little more education. It involves you all promoting wellness in the community, keeping people out of the hospital. I once had a hospital CEO tell me, if we're doing our job effectively within the next 10 years, this hospital will be half this size because we'll be rendering more care outside the hospital. Hospitals will be for really sick people. This is a new revenue stream that EMS can look at. It elevates the experience and education of the staff. You basically partner with area hospitals to work with their discharges to keep them from being readmitted to the hospital for the same signs and symptoms, which they won't get paid for, in a short period of time. And hopefully, if you keep people well and in systems, then it reduces unnecessary ambulance transports, things you're not going to get paid for. You know, there's all kinds of ambulance designs out there you can think about. You can have a private service. You can have a franchise that's not exclusive. It could be volunteer. It could be hospital-based. The fire guys could do it. You all have chosen the EMS Third Government Service, and quite frankly, I think that works well for you all. I think that's a good match. I think it's working well, and it seems to be serving the community pretty good. So, wow, that was a lot of stuff really fast. I didn't really get into the meat of the report because you can read that. But I wanted to hit the highlights and kind of tell you how we did this. And if you have any questions, I'd be happy to address those.
Yes, I do, Mr. Little. You mentioned earlier in your report about raising the cost per call by about $100. You also mentioned discontinuing the discounts to the $175 for residents. And then you also mentioned that the cost per call now is about $1,075, is that correct? And then you said something about other agencies or other ambulance services that are busier, their cost per call is $500. Now, I'm a little bit confused about how we're to drop our cost per call, yet raise the costs and eliminate the discounts.
Okay, let's define a couple of terms first. Cost per call is what it costs you to do the service. And that's $1,075 a call. That's basically you take your total expenses and you divide it by the number of transports you have, and that's your cost per call. It has nothing to do with what you bill. Your billing costs are inflated because you know not everybody can pay what you charge. We know that under the Medicaid program, they pay a fixed fee schedule, probably close to $150 or something like that. Doesn't match what your cost to provide the service is, but that's all you can collect from them. Medicare also has a fee schedule. They pay much more than that, but probably doesn't cover your cost to provide the service either.
And then that means, if I can figure out what you're saying, if we raised our rates by 100 and eliminated the 175, we could be reducing our cost per call by between $100 and $275 a call, right?
No. Your cost per call is what it costs you to do it. Your charge is what you bill people to do it. What you will be doing is your cost is your expenses. It's the fuel, it's the insurance, it's the people, it's what it costs to put that ambulance out there. Your billing charge is what you're billing people to ride in the ambulance and receive services. Two really have nothing to do with each other. So you can raise your charges to the people, collect more money from insurance companies, and bring more cash or revenue into the system, but it's really not going to affect your cost to do the call. To change the cost per call means you need to reduce something and cut your expenses. It has nothing to do with what you charge people for what you do. So when you look at there's an expense side and there's a revenue side. The two don't blend together at all. The expense side is what it costs you to do it. The revenue is how you're trying to bring cash in to minimize your subsidies. And the more you charge, especially the insurance carriers, the private insurance companies, will pay pretty much whatever you charge them. And your charge rates really aren't that high. And I'm sure some of these people at Aetna and Blue Cross and Travelers are saying, yeah, I'll write that check, because they could be charging me a lot more. And you're not. You could be bringing in more third-party money and supplementing, reducing your tax need because of your revenue side. It has nothing to do with your cost.
you explain a little bit to the board the resources that you will provide Brian from this point forward?
Okay. As a affiliation with our firm, as Brian needs to work through the recommendations that we've given him, it's part of our services that I will provide him some templates. I'll provide him some sample contracts. I've offered to even let him send me his revised data after he can separate out the transfers and the 911s and what the new volume looks like based on the fact that we've lost, was it Mound View's non-emergency work and some of these other things. I'll run these maps again, and I'll run, when you guys actually move into Hancock, if you do that, actually, I think in the back of your book, you've got a drive time map of the Hancock station that if you implement that, you can see what you will cover. And we'll basically take your data from 2013 and we'll rerun it and give you some new reports. And if Brian or Deb or any of you have questions and you want to talk about something, the community paramedicine, you want some more information, we'll be happy to give that to you, and we're not going to charge you for that. That's just part of being one of our clients. We offer a conference every year that's made up of EMS leaders throughout the country. It's called Pinnacle. It's actually going to be held in 2 weeks down in, this year it's in Florida. Why we picked Florida in August, it must have been cheap. But we have EMS leaders from all over the country come to that, and we offer our clients a reduced fee to come to that conference and learn what's going on in the industry. So we don't just walk away today after this. I'm available for Brian anytime he wants to call me and chat about something or just run an idea across me. You know, you guys have a good operation. This EMS system works pretty good. The community likes you. The hospitals like you. The employees like the work that they do. They seem to be pretty good at it. They look good. Brian's a good leader. He's new. He's getting his feet on the ground. He's interfacing with people well. I wasn't able to do a management survey on him because he was too new at the job, but I think he was a good choice. I think that's going to work out well for you. So you guys are doing a lot of the right stuff. And it was a lot of fun working here. I want to thank the EMS people for the time they spent with me, bending my ear, telling me about things. With Deb and her thoughts on the leadership, and of course Brian and Jeremy and the work that they do. And then when I met with you guys while I was out here, we talked for over an hour and a half in a session about EMS stuff, and the information you gave me was very helpful. I appreciate that. So thank you all very much.
Action on the following resolutions and ordinances.
Resolution number 26-7-13, acknowledgement of Elizabeth Corning's service to and retirement from Waushara County.
Motion by Eckstein, second by Bernadette. Any questions or comments? All in favor?
Aye.
Opposed, same sign.
Resolution number 27-7-13, resolution ordering the issuance of tax deeds on certain tax foreclosed property.
Motion by Joe Piaski, second by Bob Wadle. Any questions or comments? All in favor?
Aye.
Opposed, same sign.
Resolution number 28-7-13, acknowledgement of Irene Warwick's service to and retirement from Waushara County.
Move to approve.
Motion by Dennis Weddy, second by Larry Crawford. All in favor?
Aye.
Opposed? Consideration and possible action on the following resolutions and ordinances continued.
Resolution number 29-7-13, resolution to create Waushara County Death Review Team.
Move to approve.
Motion by Reddy, second by King. Do we have any questions or do we need any information on this? Ruth? Is this your?
This is Patty's.
Oh, Pat. Okay, Patty, you want to explain or?
evening. Presently, in about 37 counties out of the 72 in Wisconsin, there are child death review teams. The reason ours is called a death review team is that in the initial meeting that we had the 30th of May, as many of us discussed with the statistics that we have with Sheriff County, we need to throw a little wider net. Many of the things that we have for our data that we have, which shows that from about 2007 to 2011, a lot of our unintentional injury are actually accidents, and that is from the ages of 0 to 24. So we're looking at young adults also, so we're not just looking at children per se. So we said death review team, not just child death review team. We also have a lot of emergency room visits, which were for poisonings. That actually went down from 2007 to 11. And we have a lot of injuries from falls and then from things that struck children, and that was from 2007 to 11 also. So that's the data that we have, and it also compares us to other counties just to give us some sense of data that says what really goes on in our community. We certainly know that in the recent past we have an issue with alcohol and drugs more as much as alcohol, and we certainly can say motor vehicle accidents and drownings have been a big issue in just the last couple of years. Now, certainly there is that sense that we don't wait for anybody to die to do anything, and you know that prevention activities are already going on in our communities. This is just what the death review teams are comprised of. Our significant number of people like coroners, law enforcement, child protective services. There's usually a corp counselor or DA sits on the team, public health, medical providers, hospital members, school members, child care members, mental health, and EMS, and they share information. And one of the reasons you have this resolution tonight is for that reason, because it needs to go through human services to allow them to share confidential information. That team sits around and really drills down to the information that surrounds the death and looks at, is there any recommendations that can be made or met for prevention reasons. So that's what a death review team does. It looks at past incidences. Questions from anybody?
Who does the team consist of?
The people that I just mentioned, but I'll say that again.
Okay.
It would be someone from the coroner's office, law enforcement, child protective services, DA or corp counsel, public health, medical providers, hospital members, school members, child care, mental health, EMS, and usually somebody around the situation that just happened. It could be, if something happened in Wild Rose, it might be specific ad hoc members from that situation. But there's people that usually sit on what I'll call a steering committee. Those are the people that I just mentioned. Usually the decision as to what gets reviewed is done by the coroner and the co-captains of the team, which usually are public health in the hospital. Yes, you had a question, I think.
It seems to me that the coroner would be the one that be in charge of this, not the health department.
The coroner is an integral part of it. We're just the ones promoting getting it going.
Why isn't the coroner doing it?
He's a part of it. He'll be part of it. Usually public health is the one that gets things moving in every one of the counties.
Talk to the coroner?
Yes, I have. Yep. Yep.
Any other questions?
So, the people on this team get some remuneration, or how is that handled?
Do they get what?
Remuneration?
No, it's all volunteer. Nobody gets paid.
Part of their job in their agency they're working at.
Potentially, but some people might just choose to do it and not get paid. The public health department will have some funding behind it. I'll probably give them lunch or something, but it's not like they're going to get paid. So it's strictly voluntary review process. Come if you can.
All right, we have a motion and a second. All in favor?
Aye.
Opposed?
Resolution number 30-7-13, acknowledgement of Steve Bray's service to and retirement from Waushara County.
Motion by Eckstein,
Second?
second by Weddy. All in favor?
Aye.
Opposed? Same sign.
Ordinance number 562, ordinance amending Washera County zoning maps pursuant to the authority granted in Chapter 58 Washera County Code. Zone change, Flight Family Farms 2 LLC, Town of Richford.
Motion by Leo, second by Crawford. Any questions, comments? All, yes.
Is this the former property of, I can't say.
Harlan Bueller.
Harlan Bueller is what I thought.
Yes.
Okay.
Any other questions? All in favor?
Aye.
Ordinance number 563, an ordinance repealing and recreating Chapter 2, Article 4, Section 2-315, Washera County Code.
Motion by Krenz, second by Bob Jones. Any questions or comments? All in favor?
Aye.
Opposed? Same sign. Appointments, and I'm going to ask that we table the East Central Wisconsin Regional Planning Commission. We have appointed someone, but the governor's office said we have to send an additional 5 names in, and they get to choose, you know, who we're going to appoint. And we're fighting over, I think we should get to choose, but I'm working on that. So if we could table this till next month, I would appreciate it.
Move the table.
Thank you, Bob. Is there a second? Okay, second by Larry. All in favor?
Aye.
Opposed, same sign.
Good luck.
Okay. Right. Transportation Coordinating Committee, Paul Gucci, Watoma, term July 2013 through May of 2016. Charles Robinson, Coloma, term July 13 through May 16, July 2013 through May 2016. Kate Surprise, Watoma, term July 2013 through May 16. Any motion to approve?
Motion?
I'll second that.
Motion by Bob Waito, second by Bernadette Krenz. Any questions? All in favor?
Aye.
Opposed, same sign. All right, does the board have suggestions for future agenda items? No. I think it's great that Mr. Little came here and explained all this to us. It was, I think, very informative and, all right, Everett, motion to adjourn.
Second?
Third.
Buddy, all in favor?
Aye.
Same sign.
All right, go to your main screen.
We're out of here.
The meeting wouldn't be complete unless you adjourn.
Without ever.
Hit the OK button. All right, now go down to the gear. Click down. Click down the arrow. One more click, now left. Left click, then the gear. Click OK. And yours will say sound. Hit OK. Yours will say volume. Click down one. Hit OK. Hit master volume, hit OK. And now click the top button. Click, yeah.
Time to
The
go
up
home.
button, yeah. Click it up to how loud you want it to be. And then hit OK.
Are you gonna break trail to the west there, Bob?
Got it.
Okay, all right, so I'll ring now.
Yep, it will.
All right, thanks.
Sure. It's easier to play with.
No, we're off this
I
month.
don't think.
And right now, we've only got one for next month.
Last one I had.
Yep, but they got a lot of variants.
I put 'em in.
Well, this one went into Souls Creek in my pants pocket when I fell in. In fact, I caught in the mud and I fell in. Shit, now what? I went out there and talked to TJ, took the battery out and put everything in a fixed price for a couple, 3 days and it dried out. It works.
Yeah, he told me that.
Yeah.
I don't know if I learned anything or not.
Didn't? High five, man. No, I thought that was really interesting.
Yeah. Fitting.
Thank you.
It'd be nice if that was. Thank you.